Okay, so moving on to clinical features. So how do these patients present? So the symptoms on the left tend to be what you would think of in patients with heart failure or progressive lung disease. They're dyspneic on exertion, they have chest pain, they may have some palpitations. Because of this right heart failure, patients who present very late or with very advanced disease with exertion can actually become faint, and they actually develop syncope. And that's a very ominous sign of very advanced disease. With any sort of heart failure, they can develop weight gain, increased abdominal girth, lower extremity swelling. But the most important thing to remember is this, you know, a lot of people think of heart failure and they think of left heart disease, but this is not a left heart failure problem. This is a right heart failure problem. So you don't tend to have the orthopnea. You don't tend to have on the right here the crackles that you would expect in left heart disease, because remember, this is starting at the precapillary arterioles. So you will have quiet lungs, but you'll have signs of right heart failure. You will have tachycardia, you will have an elevated neck vein. On heart exam, you might hear more signs of right heart failure, so a prominent P2, a systolic murmur at the left lower sternal border because of tricuspid regurgitation from high pressures in the lung. You might feel an RV heave, and you'll see a lower extremity edema and ascites, but again, clear lungs, no orthopnea. If they have crackles, if they have orthopnea or paroxysmal nocturnal dyspnea, that's more suggestive of left heart, and I'd look more on the left heart side, okay? And then how do you sort of suspect it in a patient that you're seeing? And I think still, I rely a lot on my history, okay? So if somebody comes in with suspected pulmonary hypertension or potentially an echocardiogram that shows evidence of pulmonary hypertension, I will say, well, what are your risk factors? And I'll ask very clearly about, do you have liver disease? Do you have anything going for autoimmune disease? Do you have a history of HIV, blood clots, so on and so forth? And again, sometimes pulmonary hypertension is the first presenting problem of a disease process. So somebody may present with that and not unknowingly have lupus or scleroderma. So we've definitely diagnosed some patients with other diseases. So I will ask them about associated symptoms. Do you have joint aches? Do you have rashes? Do you have skin tightening suggestive scleroderma? Obviously, family history would be important. And then we tend to really dive into drug history, because we know that there's a clear link between pulmonary hypertension and drug history. And these are the pathogens that have been associated with pulmonary arterial hypertension. So unfortunately, in the United States, particularly where I am in California, we see a lot of methamphetamine use, and some derivatives of methamphetamines like amphetamines can be associated. Diet pill use, we'll ask patients if they've tried to lose weight, and so agents like fenfluramine and Minerax are basically in diet pills here. In Europe, this rapeseed oil was identified in the past, and I think now is no longer available. So, you know, I always take a very extensive social history, and I think, you know, this chart is still alluding to the fact that we're still identifying further and further new agents that might be involved with this disease. Even though it says cocaine here is a possibility, it's really not a strong possibility. And then some of the more common drugs that we see, like heroin and things, it's really not associated with this disease. So really methamphetamine is the illicit drug use that we see. So how do we move on to diagnosis? Well, like I said, the most important thing is to do a thorough history, but then we also move on to testing. So because of the fact that we don't want to miss any of these associated diseases, we will check serologies for hepatitis, HIV. We'll at least send an ANA to look for anything going for autoimmune disease. We'll do a liver ultrasound to look for liver disease. Group 2, we'll make sure we get a good quality echocardiogram and an EKG to make sure there's no evidence of left heart disease. The group 3, we'll definitely do breathing tests or pulmonary function tests. and we'll at least get a chest x-ray and often a chest CT scan to check for any lung disease. And in patients who screen positive, we'll get a sleep study and an ABG to look for CO2 retention or hypoxemia. And then group 4, CTEPH for chronic thromboembolic disease, we'll get a VQ scan or a CT chest angio to look for chronic clots in the lung. Okay, so it's a pretty extensive workup. But I will say, I know that not everybody has access to all the things that we have access to here. I will say that you can pick up some hints on usual testing, and sometimes it's just overlooked because I think we're so focused on looking at the lungs themselves. But this, for example, is an x-ray of one of our patients here, a young woman who unfortunately was diagnosed with idiopathic pulmonary arterial hypertension. And you can see really unimpressive lung fields per se, but you can see these very large hilar opacities here. And obviously, we can't be for sure that these are not lymph nodes or something that's associated with that. But what I'm trying to point out is these are actually her pulmonary vasculature on the right and on the left side, and they're very enlarged out of proportion to what you're typically seeing. And so even though this is a disease of very, very small vessels, over time, that back pressure goes back into the more proximal vessels and causes enlargement of those vessels. And so that's a very clear sign that you can see in somebody who is a young woman or, you know, has a history of HIV, who comes in and is short of breath and is not meeting criteria for other more common diseases. And then even a simple EKG can give you some hints, okay? So you can see these deep T-wave inversions in the inferior leads and some of the precordial leads, suggestive of right heart strain. You can see this S1 Q3T3 pattern, which is suggestive of right heart strain, which we always think about in acute pulmonary embolus, but in patients with pulmonary hypertension and chronic right heart strain, you can see it. And then you can see the peaked P waves, which are suggestive of lung disease, right? P pulmonale, very peaked P waves can be suggestive of lung disease. So this is a very good EKG for right heart strain and potentially pulmonary hypertension or core pulmonale, as we always, you know, mention. And then echocardiography is kind of the most commonly used screening test, right? So somebody comes in, they have signs of heart failure or they're dyspneic, and we're trying to figure out what's going on. We'll get an echocardiogram. So I already went through some of the findings on this panel here, but how we identify pressures in the lung on an echocardiogram, it's based on tricuspid regurgitation, essentially. Okay, so these patients will have a lot of leaky tricuspid valves because of this back pressure from the lung. Okay, and that's what's evident here on this panel. And we use this velocity of the tricuspid regurgitant jet, and then we add it to the right heart filling pressures, which is, as you may know, we look at the collapsibility of the inferior vena cava on echocardiogram to tell us the filling pressures on the right side. And so this velocity here plus this right heart pressure here gives you an estimated right ventricular systolic pressure, or this is similar to a pulmonary arteriosystolic pressure. Those two pressures should be the same. And so we get a lot of patients referred for abnormal echoes and elevated RVSPs. And the cutoff number that we sort of think about is an RVSP of greater than 40, essentially. If somebody's having symptoms and they have a good story for PH, we will say, okay, well, their RVSP is elevated above 40. Let's take a better look at them. But again, as I will mention, you cannot diagnose it for sure on the basis of an echo, and you have to proceed to right heart catheterization. So as you may remember, right heart catheterization is also called a Swan-Ganz catheterization, where we place a catheter in the right heart and we measure the chambers here at the bottom panel. So RA is the right atrial chamber. It should be low. It should be a pressure of about 5 is normal. On RV pressure, as you can see, kind of goes to a level about 20 over 5. And then PA pressure tends to go to a level of about 20/10 perhaps, with a mean of about 13 at the highest. And then the PCW is the wedge pressure. That's a reflection of left heart pressures, and that should be low. If you don't have any left heart disease, it should be something on the order of 5 to 10, okay? So again, remember, coming to our definition of pulmonary arterial hypertension, still meeting that criteria. The mean pulmonary artery pressure has to be greater than 25. With pure pulmonary vasculopathy, that group 1 class, a wedge pressure of less than 15 has to be found, or else we're talking about left heart disease. And then that translates into a pulmonary vascular resistance of greater than 3 Woods units. And I think that that number is just something good to sort of reflect on for all of you sort of physicists out there. If you like thinking about physics, you can maybe remember Ohm's law, and you can think about how in a circuit, right, the flow or the current through the circuit is going to be related to the pressure drop across that circuit. So if you start at point A here and point B here, you know, that pressure, the difference between that pressure drop is going to enhance flow. And then it's going to be inversely proportional to the resistance, right? So this is Ohm's law. And if you think about the pulmonary vasculature in this way, and you think about point A being the sort of right heart or the mean PA pressure, you think about point B being the left heart or the wedge pressure, you think about the resistance being the pulmonary vascular resistance, and you think about the current going through as being the cardiac output going through. This is how we come up with this number. This is the pulmonary vascular resistance. It's going to be the mean PA pressure minus the wedge pressure divided by the cardiac output, okay? And this number is very important because this has to be quite elevated to be talking about pulmonary arterial hypertension. So here's an example that we had of a patient who presented with a young woman, 21-year-old woman, with no real prior history, who presented with syncope. And you can see, I don't have her RA pressure reading, unfortunately, but when we got into the right ventricle, you can see her pressures got as high as 120 over about, 8 or 10. When again, those pressures should be on the order of 20 over 5. And then when we got to her pulmonary artery pressure here, her pressures were about 125 over 38. Again, when those pressures should be about 20 over 10, okay? So you can imagine it's not subtle when patients have this very severe disease. And then her wedge pressure was, of course, quite normal. She was a young woman and she didn't really have reason to have left heart disease. So these were her pressures on the right side in the patient in the red. These again are just your reference for normal. And so her RV pressure was, nearly 6 or 7 times what it should be. Her mean PA pressure was 75, and her cardiac output was a little bit depressed, and her pulmonary vascular resistance was about 17 times what it should be. So you can imagine it's almost like an obstructive shock. She cannot put blood through this very high pressure system, and therefore she developed chronic right heart failure.